Well, we'll go ahead and get started. We appreciate everyone's joining us this evening. We have folks coming from around the country tonight to participate in this conversation. We're very, very grateful to have you all here. My name is Matthew Hughes. I'm the Executive Director of the International Relations Council in Kansas City, and it is my pleasure to welcome you to this evening's presentation of Balancing Public Health and Privacy Concerns During a Pandemic Response. Tonight's speakers are Associate Professor at the University of Kansas Medical Center and 2019 recipient of the International Relations Council's Award for Academic Leadership, Dr. Sarah Kessler, and former FBI Special Agent in Charge Michael Tabman. So Dr. Kessler and Michael, thank you so much for joining us this evening. The International Relations Council is a nonpartisan, apolitical organization that provides a platform for the greater understanding of international topics and how they intersect with the Kansas City community. We would also like to welcome members joining from around the country. This event is part of C by C Amplified, an ideas summit presented by the World Affairs Councils of America Network. This week, councils from around the US are working together to highlight the power of our network. We encourage everyone joining us today to support your local World Affairs Council. If you would like to ask a question throughout the program, please feel free to submit it through the Q&A feature on the bottom bar of your screen. We will try to get to as many as possible. And if you would like to connect with us, please feel free to log onto our website at irckc.org, which will also be linked for you in the chat box. Thank you again for being here. The order this evening, Dr. Kessler will start talking about some topics related to public health. Michael will go next talking about issues related to privacy and security, and then we'll bring it back together for Q&A. So without further ado, Dr. Kessler, over to you. Thank you so much.
Okay, thank you. Let's see here. Okay, thank you. It's so nice to have the chance to be with you guys and have this timely conversation. As Matthew just noted, I just talk a little bit about from a public health perspective. I know everyone is saturated with the news right now, so not probably going to tell you anything you don't know on key updates of COVID-19, but just talk a little bit about the public health perspective versus maybe a medical lens of looking at this topic, some of the tools that we use in public health to try to address pandemics. And then spend just a little bit of time giving a few examples and highlights of some technological tools and apps that are being used in various countries to address COVID-19. So I think, everyone is well versed, I think by now, on some of these key facts related to COVID-19. And the fact that this is really a novel coronavirus, it's new to our human population, has what's made this, any pandemic that we would be experiencing would be very challenging. But the fact that we are feeling like we're starting from ground zero in so many respects, from, mapping the viral genome to then developing diagnostic tests, going through this process of trying to figure out what may work therapeutically, the march for a vaccine, all of this, starting from sort of a baseline, almost of zero, to move forward on this. I know everyone's aware how easily transmitted this virus is. I'm sure you've heard the term R0. This is this estimate we use in public health of how easy it is to transmit the virus. So estimates of this have ranged from the data from China and from the US and other places, but basically for each person who's infected, this is an estimate of how many other people they are likely to transmit the virus to. So that ranges anywhere right now between 3 and a high of 5.7 people. And keeping in mind, if we are going to contain this virus, we need to get an R0 value less than 1 to reduce and stop the spread. I know everyone's aware of respiratory droplets that can linger in the air or much longer on hard surfaces. We have an incubation period within this range, but it's about 5 days is what we're commonly seeing. And what's making this so challenging from a public health perspective to address is that not only is it very easily transmitted, but asymptomatic and pre-symptomatic transmission makes this really difficult to get a hold of, especially in the absence of widespread testing. We've recently opened up our testing now to asymptomatics. That's a very recent development, and that's going to be key to really helping us better describe and understand what's happening in our communities in regard to prevalence. We still have effective strategies that we're touting, hand washing, covering our coughs, some of the basic hygiene strategies, physical distancing, making sure we stay at home if we're sick. There's still many known things that we can be doing to reduce the spread. But as I mentioned before, I think, we're seeing, even the absence of a vaccine, we're really seeing some encouraging team science and synergy as groups are working, being very open and sharing, trying to advance vaccine development. So we've all heard kind of 12 to 18 months till we have a viable vaccine may be the case, could be a little sooner. But then when we really think about widespread distribution, and not just in our country, but making sure that people have access to a vaccine around the world, we're looking at a number of years for sure. And while there's no treatment that we have yet, there's, as you all are hearing about, these clinical trials ongoing, looking at various antivirals, antibody therapies, convalescent plasma, and different immune response modifiers are all some of the key categories of treatment that we're investigating. And if you're not familiar with this website, this is great. The Johns Hopkins, they have a COVID resource center. But this is where you see, this is probably running as a ticker along all the news stations as well. This does daily tracking of cases. And so this is looking at our global estimates right now. And I pulled this morning. I just went to check it right before the talk. And we're now at 3,742,046 cases worldwide, with 262,709 deaths. And if we look at the contribution of the US towards those global numbers, about a third of the new cases are occurring amongst Americans, and about 27% of the total deaths that we're seeing globally are also amongst our fellow Americans. And those are those numbers of the total cases and the deaths that we're seeing. This slide is giving you a snapshot of what's happening at home here for us. So these data are from this morning. From the New York Times report that had come out. And this is showing this larger graph is showing sort of our curve. And so we're seeing in the month of March, we see that steady incline in the slope, but at least we're seeing a nice leveling out. Now this is nationwide data. A lot of times we're looking at our regional data, but this, if we look as a country, we've got about 1.2 million cases right now and over 71,000 deaths. But we are seeing a plateauing, at least nationally, in the curve and flattening the curve with the really concerted efforts that we've had with the stay-at-home orders. And so now we have yet, to see what will happen as we ease some of those restrictions. I wanted to give you a quick snapshot of home, looking at Kansas and Missouri. These are from this morning, and I think we see that continued climb upward. And I know, as you guys are aware, we've had recent outbreaks, recent number of cases diagnosed in our meatpacking plants in both of our states of Kansas, Missouri, and other Midwestern towns that are really driving those spikes upward right now. And I just want to spend a moment to kind of contrast a public health perspective during a pandemic compared to maybe a clinical or bedside perspective. And in many cases with new novel viruses or pandemics, it's often identified first by a clinical practitioner who is seeing an unusual case or clinical representation that doesn't look normal, and they start to investigate the issue. This is how we found out about HIV in the 80s, providers seeing very unusual presentation, and this is how Dr. Lee in China raised concern and alarm when he was seeing unusual clinical presentations. So often first it's our clinical colleagues that identify this, but when we look at a population health view, it's our field of epidemiology within public health that really takes front and center. And these key questions that we're looking at from a population perspective is, how is it spread? What is the incubation period? And these, this is like investigative epidemiology. So it's looking case after case, trying to find commonality, similar exposures, and just mapping it like an investigative puzzle is essentially how we start to answer these very early questions in an epidemic outbreak. Who is most vulnerable or at the greatest need for protection, looking at mortality rates, morbidity rates, seeing which groups in our population seem to be most vulnerable, having the most severe presentation. And these are some information that we learned early on in this pandemic now. When did the first cases begin circulating? So when we don't have widespread testing, this can become tricky to really make sure we've got a good grasp on this. We've seen data from medical examiners coming in to really help fill in some gaps and see that the virus was here much earlier than we had anticipated or originally thought. Where is the virus spreading? So one of the tools we like to use for this is GIS, the Geographic Information Systems, that really help us plot and be able to see in real time, like the map that you saw from the Johns Hopkins website that really gives these images of where we're seeing a density of cases and where we need to focus our resources and interventions. But all of these questions that we want to figure out within epidemiology is to help inform evidence-based interventions in our health policy. Where do we need to, what's the most effective way to channel our resources and efforts? So some of the key public health tools, and then I'll get to the technology because I want to get to the crux of our talk today. But surveillance, we think about and will be a topic. I know Michael will be talking more, but thinking that our public health system, surveillance is a backbone of that system. We have active surveillance measures. Typically, we work on a passive surveillance system. Just very recently, we're starting to take a sentinel surveillance approach to trying to see some of the data that's come out in Los Angeles and New York, where we've taken segments of the population and tested everyone, not just symptomatic people, but testing everyone to try to get a sense of the prevalence and antibody presence in different populations. But case and contact tracing is bread and butter for public health. It's not new. We used it for STIs, HIV, but now we're needing to use this at a scale we really have not encountered before. Isolation and quarantine, very from the early days of public health, those have been strategies that we still find relevant. Travel restrictions, the social distancing, all of these sort of fall into these non-pharmaceutical interventions that we use in the context of a pandemic. And then looking at innovative technology that's been emerging, and we see this in the form mostly of apps that have become available. We're seeing them target symptom tracking, contact tracing, and sort of real-time surveillance of data. And the sense is that, if enough people can be using these apps, that this can be more effective and certainly more efficient than some of the traditional door-to-door, traditional methods for contact tracing. And they've run some models looking at an outbreak in a city of 1 million people and estimated that they could halt the spread of transmission if they're able to get 80%, which is a high bar right now, of cell phone users using these types of apps and tracking devices. And so in light of that and in light of our situation, there is some advocacy to look at exempting some of these COVID apps from some of the typical privacy restrictions that are in place. There's also a lot of concern about that, and I want to share a couple examples with you. This is for symptom tracking, so just reporting your symptoms. This app from the UK has been quite popular. It's got over 3.5 million users and probably many more now, but it's completely voluntary, it's anonymous, and it gives you, it's about a minute it takes, you log onto the app, you get it, and you self-report your symptoms. And thinking about especially here in the United States, when so many people needed testing and couldn't get tested, you had a lot of symptomatic people with nowhere to resolve, what was happening with them. And so in these cases, we saw a lot of uptake in trying to report symptoms. And just here at home, our Wyandotte County Health Department, they didn't have an app developed, but they created a link on their website and encouraged people in Wyandotte County who couldn't get testing to report their symptoms. And then the health department has continued to follow up with those people who reported symptoms to now try to make sure they get testing and to see how they're doing and following back up. So this is one way we saw a sort of a quick response to being able to report symptoms. But what we're really seeing a lot of focus on is this contact tracing strategies. And I wanted to give a couple examples from government-owned apps that have been mandatory. So in China, you may have already read and heard about this, but they have this color-coded sort of risk assessment. And it's required by authorities, if you wanted to basically leave your apartment and to move about publicly, you need to have downloaded this app because authorities will ask to review it. And it's got a QR code that gives you this red, yellow, and green status. So green, you can move unrestricted. Yellow, you are supposed to be in a 7-day quarantine. And red, you should not be seen anywhere because it's a 14-day quarantine in your home until that period ends, and then you get cleared. Sorry. And then this is another app. This is that the Indian government has mandated for public and private sector employees to use. And again, this is an effort to sort of evaluate your risk on your you have to enter in about your medical history, your travel history. It uses Bluetooth to try to locate who you've been in contact with and close to trace potential contacts, or if you've been near someone who is a reported positive, COVID positive. There's been a lot of concerns in India regarding that privacy and surveillance, and particularly this is considered, it's being requested that it's mandatory of employees. And then I want to give just a couple examples of government-owned contact tracing apps that are voluntary. So in Israel, the Hag Magen, I'm probably pronouncing that wrong, but in Hebrew it means the shield. And this is tracing the locations and compares with known movements of COVID cases that have been reported. It's trying to be a bit more sensitive to privacy. It cross-references sort of where you've been in the locations on your device rather than transmitting it to the cloud. But the point, I think, a similar thing we're seeing with all of this, the Bluetooth, is to try to be a bit more precise than what the GPS tracking can do, and to try to be able to sense other phones that you're within, 6 to 10 feet of, and record that, pick up those data points, so that if any of those people should then have a confirmed positive test, you'll be notified for yourself to go get tested. But these are voluntary. Similarly, in Singapore, they're doing something similar, and in Australia as well. And I think the governments are trying to frame this as we all want to get back to work and have these restrictions lessened. And so the more people that we can get using these apps is going to allow us to feel more secure to move about and get closer to normal practice. That estimate of 80% of your population using it, that's quite high. I think Australia's goal is at least to get to 40%. I know these numbers are evolving, but sounds like they're probably at about, some of these are at the best close to 20%. And then just a couple examples for enforcing quarantine. In the US, we make phone calls. We encourage people to stay at home. If we're lucky, we get a follow-up phone call to them. But we really, it's kind of an honor system. There are fines or jail time that could be enforced on our law, from our laws, but we rarely see that happening in the US context. In Hong Kong, they have an electronic wristband that's synced with an app, and they use geofencing technology to see if you are leaving the confines of your home that can have some penalties associated with that. You know, China use of cameras that are pointed at the door so that if you leave or break your quarantine, it could be documented. India has a new practice of stamping your hand when you come into the airport if you're supposed to, based off of where you just traveled from, have a quarantine. And then also cross-referencing any of your potential travel reservations to make sure you're not leaving and traveling. And then Matthew had pointed my attention to this one, but in Russia, the facial recognition technology to enforce quarantine. So this was not developed for this purpose. It was there for more criminal purposes and policing. But for people that they're considering sort of high priority COVID tracking cases and exposures, it seems that they are using this facial recognition technology and to track if people are breaking their quarantine in those cases. So I want to make sure we have time to get into discussion, and I know we started just a little late. So I think there are privacy concerns, as you can imagine, concerns with hastily developed software that could have glitches, thinking about the issues of safety and the duration of data storage, who's storing it and for how long. And then I think I'll save this slide and turn it over to Michael, because I think in our discussion, these can be some of the things that we talk about. But in a public health crisis, you know, how much power do we surrender to the state in the interest of addressing a crisis? These questions of how strictly we should enforce quarantine. Is it worth it for the greater good? How comfortable are we with infringing on civil liberties? And then I think we all kind of have a heightened tolerance in a moment of crisis to forgo some of our freedoms, but really making sure, and can we make sure that these are temporary solutions and that we have a clear pathway to resolving them after the crisis clears. And I think with those thoughts, Michael, let me turn it over to you.
Okay, thank you. And that was a great segue into my part of the presentation. So we want to talk about privacy and security, how they play against each other. And that's really not a new concept in public discourse. And that's because as citizens of the United States, we want to be secure in our persons, our houses, our papers, and effects. Now, some of you may recognize those words. I stole them from somewhere. Those are the words of the Constitution, specifically the Fourth Amendment. And while we turn to our Constitution for understanding our liberties, the Constitution does not specifically address what are your rights to privacy. So I think the Fourth Amendment is probably the best guiding principle that would explain that, tell us what the intentions were of the Founding Fathers. And I know that from my 27 years in law enforcement as a police officer and FBI agent, the Fourth Amendment was kept very close and dear to our hearts and our minds, because the power of search and seizure, of going into your homes, invading your privacy, was pretty well regulated. And if we wanted to stay legal and keep our cases and evidence in court, we had to comply. So let's take a look at privacy versus security. They are actually two distinct concepts, but also could be a singular concept. We want our privacy maintained. We want our security to be secure. We want to be secure, not person, places, and things. So let's use an example where they both come in play. You go to get a car, you go to a car dealership. And like most people in America, you need to take a loan out. So when you apply for that loan, what information do you provide? Your name, your address, your date of birth, social security number, income, email, phone number, all that private data you are providing to them. On the one hand, we want that information secure. We don't want anybody accessing it and doing identity theft and going out and getting loans, new credit in our names, or accessing our bank accounts, wiping out our assets. So we want it to be secure. That would come, of course, in a data breach that we see all the time. But let's say the data is not breached. Let's say this dealership or the people giving you credit sell your information, because someone in that small print gives them the right to do that. So they won't give out your social security number, your date of birth, probably those very personal identifiers, but they will give out your name, your address, your email, your phone number, your income level, and other socio-demographics. And then you'll be deluged with the phone calls and the emails that you just don't want, the robocalls, the spam. And that's not just an invasion of privacy, that's also a security concern, because we know that certain people are just vulnerable to fraud over the phone or over the internet. And so that privacy breach turns into a security breach. So we want both privacy and security. Let's go back to the Fourth Amendment. We want to be secure in our houses and our persons. I think when we think about our persons, we're thinking about our personal bodies. We want privacy. And when we are in our own home, we expect that privacy. We want to behave as we behave, dress or undress as we choose. Now, this reminds me again of my days back as a patrolman, getting that call of the peeping Tom. So if you're in your house and you bring your blinds down, all the way down, maybe a ½ inch shy of the windowsill, you leave that little opening there, that is not an invitation for someone to creep up there and not enter your home, but look into your home. Right? They haven't broken into your home, but they're looking in. You have a reasonable expectation of privacy, even though you may have left this little opening. And therefore, someone could be arrested. Now, let's take another extreme. You leave your windowsill, your window blinds wide open, and anybody walking down the street can see you. Well, you may say, hey, I'm in my house. I've got an expectation of privacy. The courts will probably disagree with you because your expectation is not reasonable. It has to be a reasonable expectation of privacy. So what happens when you leave your house? Do you give up all your privacy? And the answer is generally yes. When you're out in public, you don't have a reasonable expectation of privacy. And that's where it comes in the issue of surveillance. Are we allowed to watch people and follow people? Now, in my FBI world, I could tell you that that surveillance was very important to us, especially if we want to follow drug dealers or mobsters. We follow them around. And we did not need any special authority. We did not need a court order or any kind of warrant, because in public, those people had no reasonable expectation of privacy. So comes a question then, is everything you do and say in public fair game for the government? Because remember, when we talk about invasion of privacy, we talk about the Constitution, we're talking about limits on government conduct. So here's an interesting case, at least I think it is, and it might be for any of you lawyers out there or your criminal justice folk. There's a Supreme Court case of Katz versus United States, 1967. Mr. Katz was engaging in illegal wagering, and he was being followed around by the FBI. 1960s, you might think that the FBI had better things to do at the time, one would imagine. But nevertheless, these two FBI agents were following around Mr. Katz. And they knew that he would go into a phone booth. Now, based on how old you are, you may not remember these phone booths. There were these very narrow structures of all glass. You opened the door, you went in, and you closed the door behind you. These agents, to bug this phone conversation, or at least Mr. Katz's end of it, planted a mic on the outside of the phone booth, on the exterior of the glass. They didn't penetrate the phone booth. They didn't enter it, which at that time was very critical to whether or not it was a legal search or seizure, a search, your phones, your privacy. And Mr. Katz was convicted, and Mr. Katz took that all the way to the Supreme Court, and the Supreme Court decided that when you are in a phone booth, irrespective of the fact that you are in public, you have a reasonable expectation to your privacy, pretty much by the nature of closing that door behind you. So even though what the FBI agents did was legal at the time, his conviction was overturned, and that would now be illegal. That would not be a proper or appropriate legal search or seizure. We would need a warrant to intercept his conversation. And the concepts and the protections of the Fourth Amendment are always changing and being challenged. Just looking back in my career, I call the issues we had when we'd go into someone's house with a warrant and there'd be a telephone answering machine. Could we listen to it? Could we not? Did we need a separate warrant? When those machines, again, going back many years, those machines went from tape to electronic recordings, that created another issue. When we got into pagers and cordless phones and then cell phones and faxes, all of that created new challenges for us, new decisions as to whether there was an expectation of privacy. And I will tell you that most of the time, the courts have ruled that when using that technology, you do have a reasonable expectation of privacy. So from that, we see that technology is a driver in determining what is privacy from a legal perspective and perhaps from a public opinion perspective. But there are other drivers besides privacy. What also drives that are events. Let's look back at 9/11. How did you view your search prior to getting on a plane? You probably didn't think about it much. It was not super intrusive. You figured it was something we needed, and you just did it. After 9/11, you were very cognizant of it. You wanted to see a lot of security. We were scared. We wanted to see a lot of security. But that waned over time, if you recall. There were sort of little protests at the airports and in general. There was a time when we felt this is too intrusive. Certain measures that TSA was taking weren't warranted for the security we're trying to achieve, and we were not willing to give up all of that privacy. And after 9/11, another conversation that was being had was that of whether or not we should torture people. And I was surprised to see there was division just amongst my ranks as to whether it was appropriate or not. And though we no longer, at least are supposed to do it by law, I was surprised that we had that conversation in my career, never mind in my lifetime. It was just not a conversation I thought we'd ever be having. So as we talked about in trying to weigh our privacy versus our security, the question is, what are we willing to give up? So right now we are looking at an attack on our security, not from a foreign military in the traditional sense, putting China aside for a moment, but from a virus. The virus is the enemy. And we can see now a significant divide in public opinion. We have those who want to move slowly and cautiously, and then those who say, open the country, you don't have a right to take any of my privacy away or any of my rights away, and we're going to take the risk. One thing I do wonder about, if this virus was man-made, we knew for sure, it wasn't speculation, rumors, we knew for sure this was man-made, deliberately introduced into society, what would we be looking at? We'd be looking at terrorism, specifically bioterrorism. And that is not a new concept either. All my career in the FBI, bioterrorism was something we were concerned about. We knew it was possible, it was a possibility. Again, putting aside China, let's say we had a named, identifiable enemy, terrorist organization, such as ISIS or Al-Qaeda. Would people feel differently? Would they be more willing to give up some of these rights that they're demanding in a fight against an identified terrorist group? I don't know the answer, but I suspect the answer would be yes. So we have events, we have technology that's changing how we view the benefits of our privacy versus intrusion. Some of the technology that the doctor talked about, for example, cell phones, cell phone data for tracking. That is surveillance, watching where you go. How comfortable are we with that? Let's look back, post 9/11. NSA, National Security Agency, if you recall, started collecting bulk data, information on the telephone, of our telephone. They weren't recording our conversations, or at least that's what we were told. But supposedly they were only collecting data on your data, like such as who you call and who calls you. That in itself, in that static sense, I never saw as a huge threat to our privacy. If someone was able to hack in to NSA, what would they do with that? And I was kind of comfortable with it in the sense that I knew from my experience, again, especially against organized crime, and drug cartels, that is really critical information to an investigation. But ultimately, as a public, we did not like it. It was just too much power. And the question is, what can all that power lead to? We talked about facial recognition. Much like fingerprints, that's based on very specific, unique characteristics to your face. That can be highly accurate. It can be, but not always. For that to work, you have to have optimal conditions, a very clear picture that you're comparing it to, and what you're looking at. So the video or the camera picture that you're looking at has to have be fairly bright, has to be getting the face at the right angle, because otherwise it is susceptible to errors. And that's okay. We don't expect anything to be perfect. So when we have government with all that kind of power, that technology, that intrusion, it's important that they use that power prudently. And they don't use these elements like a match on a facial recognition as absolute evidence that someone committed a crime or violated a quarantine. Use it as a lead. Make sure you understand who it is you're talking to and what the situation is. So the government does have a lot of power in a national emergency such as a pandemic. We know they can impose curfews, they can restrict gatherings, they could put restrictions on interstate travel. And the doctor spoke about our privacy, but even now the Department of Health and Human Services has relaxed some of the requirements, the HIPAA rules, as we know them, the HIPAA on your privacy, regarding the disclosure of information, because we feel it's beneficial in the name of public safety. We talked about a quarantine. We know the CDC can do that. We also know state authorities can quarantine you. And that's the fear we have, is that many people believe that once the government has these powers, will they relinquish them? And some of the ways that's been addressed in statutes and legislation is through a sunset clause, where that power expires at a certain time, maybe several years down the road, and it's revisited to see if the situation has changed. Do we need to maintain those powers? And if we look at the Patriot Act, we see some of those sunset clauses were not renewed. So how do we find this balance? There's no easy answer. There's no universal agreement. So what we do know is we want the government to be responsible. But we also need to be reasonable in the way we exercise our rights. In this country, we live by the rule of law. If you disagree with the law, you can't petition your legislators. You can peacefully protest. You can vote your legislators out of office. But if we all break the laws or don't respect the laws with which we don't agree, then we no longer have a civil society. I'm going to use a quote here that I found in all places on Facebook. Some of you may have seen it. It was without attribution, so I'm just going to say it with credit to whomever came up with this. Insisting on your rights without acknowledging your responsibilities isn't freedom. It's adolescence. Now, that is a bit condescending, but I have to kind of agree with it. If you arrive at an angry protest, getting in the face of police officers while you're carrying a firearm, you're asking for trouble. If those continue, they will eventually turn deadly, without question. Recently, we've had a forest ranger assaulted. We've had a security guard killed, merely for asking people to comply with the rules. This does not represent a civil society. When we think about those we've lost, those who will be lost, all the suffering that this virus has caused and will cause, I think it's fair to ask people to consider, how important is your right to spend the day at the beach? We have tough times ahead, but we have to emerge from this crisis stronger and better prepared for the next crisis. Whatever that may be, whenever it will hit, another crisis is coming. As a former law enforcement officer, I ask everyone, please not only obey the law, whether you agree with it or not, but respect those who are enforcing the law. Thank you.
All right, guys, thank you so much. That was fantastic presentations for both our panelists here. Well, we want to open up the floor now for some questions and answer. And you can feel free to submit those on the bottom bar of your screen. We have one here already, and this is from Chris Allman. How well can contact tracing work since it requires a high opt-in rate and many cases of COVID are clinically mild or untested or asymptomatic? I believe this is for you, Sarah. Oh, and it looks like you're on mute, actually.
Thank you. Okay, so the question was, how effective can contact tracing be when we have the dynamic of low testing and the asymptomatic? Is that?
Yes, that's it.
Yeah. So, I mean, you have to be aggressively contact tracing in any scenario, even when you've got challenges with testing, even when you have a virus that has asymptomatic presentation. It's just one of the absolute cornerstones to trying to control the spread within a community. So, of course, it's optimal to, when we get our testing up to capacity, and that allows, I think that coupled with some additional surveillance that's going to help us better quantify our asymptomatic spread, we can see a much better return on investment for our case and contact tracing. But I think even in our current less than ideal scenario, you can't let off of those efforts. They're so fundamental.
Sure, and it looks like we have a couple of questions that are based off of that answer as well. And one of them is testing. Is testing for both antibodies and the actual virus, or how does that actually break down?
So right now, you're testing for, our diagnostic testing is for the virus. That's the nasal swab that we're typically seeing in the lines. The antibody testing is a serologic test, so that's a blood test. And that is something that we're just starting to see pick up in availability. I wouldn't say that is, I still think our diagnostic testing isn't widespread, but certainly serologic testing is not. And we have a lot of work to really understand what that means. To what extent do antibodies confer protection and for how long?
Mm-hmm.
But we're just with some of those studies some of those findings that we saw just coming out in the last week from New York and Los Angeles. I'm hoping that we'll be seeing a lot more of those, and I'd love to see some Kansas City data to understand what we're looking at here in regard to sentinel surveillance.
The next question is for you, Michael. Is it considered invasive in any fashion to require a temperature measurement of a person entering a public space or a similar situation?
Well, again, remember whether we're talking about a private facility versus the government doing that. Two different issues. I've entered many facilities, as we both have, with doctor's office, and been asked to have my temperature taken. I don't find that invasive. I don't think the courts would either, certainly not in a public environment. I think if the government starts doing it, it will be challenged. But if we look historically at some cases that might apply, such as a dog sniffing drugs at an airport, you may not have done anything. You have your stuff in your bag and you feel you have an expectation of privacy. But if you're sort of emitting something that could be detected otherwise without invading your privacy, I think the courts would rule that as permissible and not an overreaching invasion of your privacy.